Hello, my name is Dr. Dewan S. Raja. Today I will discuss about Bullous Pemphigoid. Bullous pemphigoid is a rare autoimmune blistering disorder that typically affects older adults. It occurs when the immune system mistakenly attacks proteins in the basement membrane of the skin. Basement membrane is the membrane between the epidermis and dermis, and that leads to the separation of epidermis from the dermis and the formation of fluid-filled blisters. Key features will get blisters, large, dense, fluid-filled blisters that do not easily rupture, involving erythematous or normal appearing skin. Heal without scarring unless they become infected secondarily. Location often appears on lower abdomen, thigh, armpit, groin. Mucous membrane involvement is rare but possible. Itching, intense itching, and redness may precede blister formation. Age group most common in people over the age of 60. Causes, the exact cause is not known, but it is associated with autoimmune response targeting hemidesmosomal proteins BP180 and BP230. Sometimes triggered by medication, that is loop diuretics, penicillamine, can be linked to the neurological disorder like Parkinson's disease or stroke. Diagnosis, how can I diagnose? Skin biopsy shows subepidermal blistering and immune deposits. Direct immunofluorescence detects IgG and C3 at the basement membrane. Blood test detect circulating autoantibodies anti-BP180, anti-BP230. It generally affects the elderly individual, shows a wide range of clinical presentation, site of involvement in our aspect of the thigh, flexor surface of the forearm, axilla, groin, and lower abdomen. Oral lesions are present in 10 to 15% affected individuals, usually appearing after the cutaneous lesions. Some patients present with urticarial plaque and severe pruritus. The separation of bullous pemphigoid from pemphigus vulgaris is based on identification of subepidermal non-acantholytic blister. So in case of pemphigus vulgaris, it is actually in the epithelial cell just above the basal layer of epithelial cell are affected, but here it is the problem just below the basement membrane involving the hemidesmosomes. Bullous pemphigoid is less severe than pemphigus vulgaris, and bullous pemphigoid cause more itching than that of pemphigus vulgaris. Nikolsky sign is negative in bullous pemphigoid but positive in pemphigus vulgaris. Okay, here is the image. If you look at the image, you'll find out that bullous pemphigoid. Bulla consists of dense blister, usually fail to rupture as their roof consists of intact epidermis. Blisters from the blister and also will get the ulcers from the blisters rupture. This is the ulcer from the blister rupture. Intact, here is the ulcer. Intact subepidermal blister associated with eosinophil, lymphocyte, and occasional neutrophil. Here we get those inflammatory cells here. So here we are saying linear deposition of complement along the desmoepidermal junction in bullous pemphigoid. This. This is epidermis, this is dermis, and we'll get hemidesmosome at this level. Electron micrographs showing ultrastructural features in the dermoepidermal junction. Bullous pemphigoid antigen is located in the basal portion of the basal keratinocyte in association with hemidesmosome. This is hemidesmosome, which attaches the epidermis to the lamina lucida of the basement membrane. Okay. Treatment of bullous pemphigoid: corticosteroid, topical or oral, that is prednisone, to reduce inflammation. Immunosuppression such as azathioprine or methotrexate. Biologic rituximab in severe or resistant cases. Antibiotic tetracycline or doxycycline may have an anti-inflammatory effect. Prognosis with treatment: the prognosis is generally good, but the disease can persist for months or years. Severe cases may be life-threatening, particularly in older adults with comorbidities. And that's all about the bullous pemphigoid. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.